This is your weekly fix. I'm Smitha Nair. Alexander Fleming's discovery of penicillin in 1928 led to the introduction of antibiotics. It revolutionized the field of medicine forever. Diseases previously considered dangerous, fatal, became treatable. Antibiotics vastly reduced deaths from bacterial infections and infectious diseases. However, the more an antibiotic is used, the more the bacteria evolve resistance to the antibiotic. How does that happen? You are no doubt familiar with Darwin's theory of natural selection. Organisms that better adapt to their environment are more likely to survive and pass on the genes that helped their success. Now, individual bacteria undergo random mutations. Some of these mutations make it resistant to antibiotics. They pass along these mutated genes. Over time, resistant strains of bacteria proliferate. As a result of drug resistance, antibiotics and other antimicrobial medicines become ineffective. As per an estimate of a United Nations interagency group on antimicrobial resistance, up to 10 million people a year could die by 2050 if no action is taken. Last week, the Indian Council of Medical Research released its fifth detailed report on antimicrobial resistance, trends and patterns from the country. And it is bad news. The report says there is a sustained increase in antimicrobial resistance in India, meaning certain infections are becoming untreatable with available medicines. Dr. Kamini Walia, senior scientist at ICMR, led this study. She's agreed to help us understand what her team found. Thank you for making the time, Dr. Walia, and welcome to Scroll.
Good afternoon, everyone. Thank you for inviting me on your show.
Right. Dr. Walia, right away, broadly, if you could explain to our viewers, what does the drug resistance data that your team has compiled and analyzed tell us?
So, drug resistance is a problem where the pathogens, that is, mostly we are talking about bacterial and fungal pathogens here, they become resistant to the drugs which are used to treat the infections caused by these bacteria or viruses. So broadly, they are referred to as antimicrobials, which includes antibacterials as well as antifungals. And ICMR has been actually tracking this data for last almost 7 to 8 years. And we have been monitoring the trends and the levels of drug-resistant infections across the country through a group of network of hospitals all across the country. So basically, we are following up 6 pathogenic groups, which is the first one is the most important, which is Enterobacteriaceae. They cause a variety of infections. They cause blood infections, something like a neonatal sepsis. They cause pneumonias. They cause urinary tract infections. The second group is gram-negative non-fermenters, which includes Acinetobacter or Pseudomonas, and they are mostly hospital-acquired infections. For example, if a patient is admitted for treatment for some other ailment, something like myocardial infarction, and they would acquire these infections while admitted in the hospital. And most of the times, these infections are highly drug resistant because these infections are prevailing in the hospital environment where the drug pressure is very high. The other pathogens which we follow is the diarrheagenic organisms, which are mostly community acquired, typhoid. We also collect data on gram-positive infections, which cause variety of other infections in skin or sometimes in blood, and also the fungal infections. What we are seeing is that fungal infections are increasing in our country. We have the right environment for that. There is a lot of use of antifungals as well in the hospitals and in the community, which is also leading to antifungal resistance being developed in our country. So there are a variety of factors actually which lead to development of drug resistance, and key among them is overuse of antimicrobials. Excessive use of antimicrobials is actually seen as a sole driver of antimicrobial resistance, and our country has many factors which actually facilitate overuse of antimicrobials, which is something like over-the-counter available of antimicrobials. Anyone can go and purchase antibiotics and take it for 1 day, 2 days, or 3 days, depending upon when you feel better. Many a times, the treatment is not driven by diagnostics. And since good diagnostic labs are sometimes not available, or sometimes the turnaround time is very long, so doctors also are they are forced to provide empirical treatment rather than the evidence-based treatment. So, and then also there is a very high antibiotic use in animals as well. How much of that contribute to the human aspect, we still don't know. The data still is there, very patchy. But overall, the kind of milieu that we are in right now, there is a lot of antibiotic being used. And added to that is a factor that antibiotics have become very affordable now. The standard of living has gone up. Because of the affordability of diagnostics, also there is a high misuse of antibiotics. So all these factors collectively lead to increasing the antimicrobial pressure, which lead to development of drug-resistant pathogens. Now, why should we really worry about drug-resistant pathogens? Drug-resistant pathogens means that they will not respond to many of the affordable, cheaply available drugs which can be bought, and which are not inexpensive. So it drives the cost of the treatment. It also increases the mortality of the patient when a patient is infected with the drug-resistant infections. So that's why globally now there is a awareness that we need to take strategic actions to contain antimicrobial resistance globally, especially in the low middle income countries where the burden of these infections is very high and also to an extent unknown.
Okay. Dr. Valia, I have three or four follow ups to what you said. I'm sort of going to distill the information that you have given our viewers. One of the follow ups is it fair to say, as some are characterizing India and, as you said, other middle income, lower income countries as perhaps hotspots of antimicrobial resistance, given the sheer volume of antibiotic consumption in our country? I think India tops the list. I know we've heard from health officials who say per capita consumption of antibiotics is not as high as it is perhaps in the West in India. Even so, by sheer volume, India appears to be the highest consumer of antibiotics. So, would it be fair to call India a
Yeah,
hotspot
so
of
we have
AMR?
a large population, and we also have a tropical environment which facilitates, high burden of infectious diseases in general also.
Hmm.
The other problem I want to highlight here is India has a problem of excess as well as access of the drugs. Some strata in our society are using drugs excessively, whereas the other strata, which is the low socioeconomic strata, they have difficulty accessing even the simple drugs like amoxicillin or gentamicin because they cannot afford it. So we have the dual burden, excessively, as well as some populations are deprived of antimicrobials. Given this situation, the country actually has a tendency, which has been documented through many studies, that our physicians prescribe a lot of broad spectrum antimicrobials. Because in absence of definitive evidence for what is the pathogen and what is the antimicrobial susceptibility profile, the doctor likes to give broad spectrum antimicrobials, so that when they don't know whether it is a gram negative or a gram positive infection, they want to give something which covers everything. And that, I think, is something which is driving the drug resistance levels in our country. I wouldn't say it will be right to say hotspot, because ICMR data is coming mainly from tertiary care hospitals. And tertiary care hospitals, we know they normally cater to very sick patients who are severely ill. And they also have come to those hospitals after multiple treatments, maybe in the peripheral hospitals or the suburban hospitals. So we are likely to see very high level of drug resistance when we get isolates from these hospitals. And that's the reason probably we see 86% resistance to carbapenems in Acinetobacter, as has been reflected now in our report. But I'm not saying that this data is representative of general community. The general community will have less antibiotic use because they are not having the kind of pressure to treat very sick patients. So the general community data, which is also ICMR is collecting, but because of some quality issues and non-availability of certain data sets, we are not able to release the community data. But from my experience, we can say that the situation is not so bad in the community. Yet, some antibiotics are highly misused in hospitals, and some antibiotics are highly misused in community. For example, fluoroquinolones, something that we all have used for treatment of diarrhea. Our report clearly mentions that there is declining susceptibility to fluoroquinolone. So norfloxacin should not be used for treatment of diarrhea, which everyone is popping for treatment of diarrhea the moment you have one, episode of diarrhea. So there are different levels which are antibiotics which are misused in the community, and there are different antibiotics which are overused in hospital setup. So this landscape we have to understand very distinctively.
Okay, Dr. Valia, you mentioned broad spectrum antibiotics. Not everybody who's watching the program may perhaps be familiar with what that means. Could you explain what is broad spectrum antibiotics, and perhaps in a little more detail why it is dangerous, you say, the sort of irrational perhaps use of broad spectrum antibiotics?
Yeah. So there is a classification by WHO which classifies drugs into three classes. There is excess, there is watch, and then there is reserve. Excess has narrow spectrum antimicrobials, something like amoxicillin or gentamicin. That will be in the excess list of antimicrobials, which are narrow spectrum antimicrobial. They have a very well defined spectrum that these are the pathogens on which these antibiotics will be effective. So ideally, every country should be using at least 60 to 70% of antimicrobials from the excess list of antimicrobials. But then we also have a watch list, which is like a one level higher. The third generation antimicrobials are classified in the watch list. And then we have a reserve list of antimicrobials, which is something like colistin, which is something like polymyxins, carbapenems. So ideally, we should be using only most of our drugs from the excess list and some from the watch, and reserve only in very sick patients. What we see in India is that we are using antimicrobials mostly from the watch and the reserve group of antimicrobials, which are like for very sick patients. And the other problem is of using the broad spectrum antimicrobials is that there are synergies within antibiotics. For example, if you take a broad spectrum antimicrobial, it will also drive drug resistance to your other antibiotics as well. So it is a manifold effect. It is not just that, to that particular drug. And when you are using the watch and the reserve group, which is the broad spectrum antimicrobial, you are driving drug resistance in multiple pathogens, not one pathogen at one time, because those are the pathogens which are responsive to those. So, and when you are using excess of those classes of antibiotics, you are driving high drug resistance in multiple species of bacteria. So that is why we discourage the use of broad spectrum antimicrobials. But in India, large proportion of antibiotics we saw in COVID patients, we also have data from non-COVID patients. 70% or 75% of the prescriptions happen from the broad spectrum antimicrobials. So that is something that is a cause of concern and which we need to address in future.
And how does one address this, Dr. Valia? Because it's interesting you're saying this. Clinicians, physicians who prescribe these broad spectrum antibiotics, I'm sure they are not unaware of the problem as it exists of antimicrobial resistance. So how does one address this issue? Are there government bodies that can perhaps release further guidelines that are enforceable, or do we have no regulation at all?
So the intervention that helps us rationalize and encourage responsible use of antimicrobials is called antimicrobial stewardship. Now, antimicrobial stewardship is something which actually trains and encourages doctors to prescribe antibiotics very clearly. They are trained on, how to decide the treatment when you know what is the pathogen and what is the susceptibility profile. In India, we have, and in many other low middle income countries, we have two problems. One is that the infection control is not very good, whether it is in community or whether it is in hospital. Our water, the wash strategies, which is sanitation and hygiene and safe water, even those are not sometimes available in some community settings, because of which the general infectious load in a community is very high. And in hospitals also, infection control doesn't get the kind of investment and the resources that it needs. That is the reason you see so many hospital acquired infections. Now, when the doctor is not sure that the infection control in a hospital is working well, he wants to save his patient. So he will prescribe whatever he can because he doesn't want to lose the patient. So in fact, poor infection control is one driver of overprescription of antimicrobials in hospitals, as well as preventive use of antimicrobials is used to compensate for poor hygiene practices in community. And also, this is also true for something like animal or livestock, where the poultry farms are excessively using antimicrobials to save their animals from any diseases that may lead to the loss of birds and everything. The second very important component of antimicrobial stewardship is how good is your diagnostic lab. If the doctor doesn't trust the microbiologist or a diagnostic lab, he will not, because of that trust deficit, he's again likely to overprescribe because for him, again, the patient is important. So antimicrobial stewardship should be practiced in all hospital settings, in all GP settings. But then does the doctor have the everything that he needs to practice AMS? You need to provide good infection control. You need to provide good diagnostic lab. When we are able to provide these two things, only then we can expect doctor to practice antimicrobial stewardship. That is why we need investments across infection control, investments across diagnostic labs. Only then we can, think of having responsible antimicrobial prescribing.
Okay, some very, very interesting points. Dr. Walia, if one of the things that I understood from the report that I read is that antibiotics that are used, stronger antibiotics that are used in ICU settings, for instance, are also not as effective as they once were because of the antimicrobial resistance to that particular drug. Would it be correct to say that, therefore, that if this sort of goes unchecked, advanced medical care, and you sort of briefly referred to it in your first answer, that carries with it itself significant risk, like, to organ transplant, for instance, as also garden variety. For example, C-sections happen frequently in hospitals, and they could potentially be an infection risk. Now that could be imperiled, right? If there is if the antibiotics that are supposed to work in these settings, in ICU settings, don't work.
You are absolutely right, Smitha. The challenge with the antimicrobial resistance today is that, it is complicating even the simple procedures which you mentioned, like a C-section or somebody undergoing a knee replacement, or you could have a patient recovering from cancer or a kidney transplant, but you would lose that patient to drug-resistant infection, sometimes bacterial, sometimes fungal infection. So most of the hospitals, and there have been many steps which have been taken by the government as well as by accreditation bodies in India to improve infection control, as well as to make availability of clinical laboratory mandatory. So those kind of steps have been taken in this direction. But yes, the threat is very real. And the threat is something that we cannot afford to ignore anymore, because the cost of ignoring the threat is losing lives, and we certainly don't want to lose that. So something that I always refer to in my other presentations, that these are invisible victims, and there are invisible threats which are lurking in our hospitals or ICUs, and they are claiming lives which are invisible victims, because there's no system to record how many patients died because of drug-resistant infections. Because sometimes when a patient is admitted with some other medical condition, it is sometimes difficult to identify whether the patient died because of MI or whether he died because of the impact of drug-resistant infections. So this is something which we need to research in our hospital settings, in our country healthcare system. But there have been few encouraging steps, rather, I would say. First is that, ICMR launched antimicrobial stewardship guidelines in 2018. And we have trained almost 30-40 hospitals across the country on antimicrobial stewardship, and the response was very good. I mean, 30, 40 hospitals was, for such a big country, is really a drop in the ocean. But then you can just make a beginning and hope, that it moves forward, and there is a ripple effect, and there will be sensitization of other hospitals as well. Besides, ICMR has been trying to provide guidance on treatment of these drug-resistant infections. So there is one guideline by ICMR which talks about the use of antimicrobials in about 12 syndromes, how the antibiotics should be responsibly used in a very calibrated way, and realizing the importance of carbapenem-resistant organisms. Carbapenem is again a broad-spectrum antimicrobial for which we are reporting increasing levels of resistance every year. It increases by about 5% or so. And we released a guideline on management of carbapenem resistant organisms which are impacting the patients. So these are some of the steps which ICMR has taken. I agree a lot needs to be done, and the stakes are very high, and that's the reason we need more awareness and more investment in AMR now.
Right. Dr. Valia, in the course of my reading or your report and what World Health bodies have spoken about, my understanding is that the period post 80s has been referred to repeatedly in several of these papers as the antibiotic discovery void. That I think the late 80s was the last time an original class of antibiotic was discovered. Now, is it that big pharma doesn't see antibiotics as a profitable line of drug development as compared to, say, drugs for that are for long-term care, like for cancer, and that's why we haven't seen any antibiotic discovery since the 1980s? And how much of a concern is that? I mean, if this sort of continues to exacerbate this problem, the
No,
fact
it's
that
a very, very, very valid concern, and important, very important for our patients. And this has been the concern for ICMR and India as well, in the sense that the treatment options for many patients are becoming very limited, and big pharma is actually steering clear of investing on R&D for looking for new antimicrobials. And I see multiple reasons for that. I mean, antimicrobials are very different from anti-cancer drugs or anti-hypertension drugs, because with the antimicrobials, the downside is that the more you use, the earlier resistance is going to develop, and so the company has a very short time to make money on that drug. And I mean, it's actually different from other anti-cancer or any anti-diabetic drugs. So which also the companies are realizing now. Initially they were like advertising and pushing doctors to prescribe. Now I see the companies also stepping back and talking about antimicrobial stewardship and all these, appreciating what the work that ICMR is doing. So the second problem that is there for the challenge for Indian patients is that some of the drug resistance mechanisms that we have in our country are very peculiar to Indian bugs. They are not seen in the pathogens which you get in European countries, or maybe in a short time they will be traveling to other continents as well, because it's a global village that we live in now with so much travel and everything going on. But right now we are seeing few new mechanisms of resistance to which we don't have any drug in the pipeline. So essentially what I'm saying is that we have to look for solutions which are indigenous and which are made to address the requirement of Indian patients. In order to bring pharma, I mean the main pharma, to develop more antimicrobials, there have been some initiatives on a global scale, and but then we really need new kind of economic models which can provide, which can appear attractive for this pharma to really start investing in this new antimicrobial development again.
Right. Dr. Valia, finally, one doesn't quite see the same kind of panic that one sees for with with other what would seem like fairly consequential developments, such as the ICMR report. I mean, your report is fairly scary, but we are not quite seeing that being reflected in the headlines, perhaps, or otherwise. Could you paint us a picture? Do we, as some microbiologists globally have perhaps said, run the risk of going back to a pre-antibiotic era?
As I said, Smitha, this report is coming from the tertiary care. While there is a reason to be alarmed about it, but the alarm is for a caution, not to create a panic. That's not something that I expect the report to do. So, and I think this has been noticed at a highest level. There has been mention of antimicrobial resistance at the time when the National Essential Medicine List was released. There is a significant, I think, sensitization around it, which is happening through ICMR, that we are releasing the report every year, and we are kind of bringing out the numbers. The other important thing to understand here is that, there are antimicrobials which are available, which can be repurposed for treatment of these infections, and which has happened in the past as well. Colistin is something which has been revived again. It was the drug which we had discarded, and now it is saving significant number of patients. Not to say that this is the right way to do. The right way to go is improve the antimicrobial stewardship, improve the infection control, improve the diagnosis. And this will also kind of encourage the pharma companies to invest in antimicrobials when they say that we are also invested in judicious use of antimicrobials rather than a country which encourages irresponsible use of antimicrobials. So that is something that we have to collectively, as a country, all the stakeholders have to think about, that how can we encourage judicious and responsible use of antimicrobials in our country, so that we don't run out of antimicrobials as fast as we think we are doing, because of the evidence that is available from the ground. In typhoid, we have seen that when you stop using those drugs for, say, 20 years, sensitivity comes back. Amoxicillin, chloramphenicol, and cotramoxazole. This was the MDR typhoid of 1990s. But now we see 100% sensitivity to these drugs, because these drugs have not been in use for almost 20-25 years. So this is a positive message from the report that we have. The typhoid continues to remain sensitive to all the three drugs. But the drugs which are being overused, we are seeing increasing resistance or increasing MICs, which is kind of an indicator that resistance is coming very soon. So this is the message that I would like to convey to the audience, that before you pop an antibiotic, please think about it. Today, you may feel better, but it is going to impact how the medicine is going to benefit you 2 years from now, or maybe to someone in your family or in your community.
All right. On that note, Dr. Walia, appreciate you sharing your insight and your time with us.
Thank you, Smitha.